Hello, welcome to Sonography-radiology training channel. This series of videos is a scientific presentation about gynecologic imaging. This is the second video in this video series about Cesarean Delivery Complications Part 2. In first video, I explained that there are three groups of imaging findings related to cesarean delivery complications. The first one, normal acute findings after cesarean delivery, acute complications after cesarean delivery, and chronic complications. In this video, I am going to speak about acute complications after cesarean delivery. There are two groups of acute complications. Group 1, many of the same types of complications that occur after any surgery, the most common being infection and hemorrhage. Infections include endometritis, wound infections, infected hematoma, and abscess formation. Hematomas include in the anterior abdominal wound, in the extraperitoneal perivesical space, and around the lower uterine segment incision. Group 2, acute complications that specifically related to cesarean delivery include bladder flap hematoma, subfacial hematoma, uterine dehiscence, uterine rupture, Orient, and pelvic septic thrombophlebitis. In this video, I will explain the imaging findings related to these complications. The first one, bladder flap hematoma. In this clip, you can see how obstetrician creates a bladder flap. You can see here pregnant uterus, and behind it is the bladder. Here, the peritoneum is pulled from the surface of the uterus by forceps to separate it from the uterus, and a small incision on the uterus peritoneum is down, and a bladder flap is made by the uterine peritoneum, like this, as you can see here. It's a bladder flap. And finally, an incision is made on the uterus to bring out the fetus. If bleeding occurs at this site, a hematoma known as bladder flap hematoma forms between the urinary bladder and the lower uterine segment. Ultrasound will show a hyperechoic collection between the uterus and the urinary bladder. As we can see in this transabdominal ultrasound image, a heterogeneous hematoma just anterior to the uterus and posterior to the collapsed urinary bladder, in keeping with bladder flap hematoma. At CT, the hematoma is somewhat hyperattenuating and is seen in the same location with or without mass effect. Here, bladder flap hematoma in 28-year-old woman who presented with pelvic pain shortly after undergoing cesarean delivery. This sagittal image shows a high attenuation collection anterior to the uterus and indenting the urinary bladder, finding that represent bladder flap hematoma. Bladder flap hematomas can be considered normal if they are less than 4 cm in size. Incidence of this type of hematoma is up to 50%. Bleeding from the uterine incision is usually confined by the overlying peritoneum, but can spread to broad ligaments, retroperitoneum, and peritoneum. At CT, superimposed infection of bladder flap hematomas will appear as rim-enhancing gas containing fluid collections with or without multiple internal septa located between the urinary bladder and uterus in the expected region of the simple bladder flap hematoma. As we can see in this sagittal image, bladder flap abscess in 26-year-old woman who presented with fever and abdominal pain 12 days after undergoing cesarean delivery. This sagittal image demonstrates a rim-enhancing gas-containing collection anterior to the uterus and posterior to the bladder. Ultrasound will show a well-circumscribed fluid collection between the bladder and uterus with internal debris and potentially gas, which appears as a cushioning foci causing dirty posterior shadowing. As we can see here, bladder flap abscess in 21-year-old woman who had undergone cesarean delivery 9 days earlier. Transverse abdominal ultrasound image demonstrate a complex collection anterior to the uterus containing numerous cushioning foci representing gas bubbles. The second complication is subfacial hematoma. This schematic diagram helps clarify the pelvic extraperitoneal spaces around the bladder and cervix. Below the peritoneal fold is perivesical space. Further lateral to this and extending posteriorly is the perivesical space. Around the rectum is the perirectal space. A subfacial hematoma is an extraperitoneal hemorrhage that arises from the inferior epigastric vessels and their branches. In this schematic view, we can see here rectus sheath muscle, abdominal rectus muscle, deep inferior epigastric vessels below the peritoneum, intramuscular segment of perforator in rectus muscle sheath, and subcutaneous branching of perforator in subcutaneous fat layer. For better perception of this schematic view, we can correlate it with a real ultrasound image. Here we can see rectus sheath muscle, here is peritoneum, we can see here deep inferior epigastric vessels, here is intramuscular segment of perforator, and in more superficial image we can see here subcutaneous fat layer, here the epidermal layer of the skin, and we can see here subcutaneous branching of perforator. Blood can accumulate in the perivesical space posterior to the rectus and transversalis muscles and anterior to the peritoneum, continues with the space of radius or retropubic space. This paper was published at 2007, shows CT of pelvic extraperitoneal spaces, which is an anatomical study in cadavers. This axial CT image shows the extent of perivesical space with extension of contrast material from just below the anterior abdominal wall as far posteriorly as the presacral space anterior to the sacrum, means like this schematic view. This sagittal image is very important to better perception. This sagittal image after perivesical injection of contrast material shows the extension directly around the bladder into the perivesical space. Please pay attention here to adherence of contrast material to the bladder wall. Contrast media also extend posterior to the pubis in the space of radius or retropubic space as a continuation of the perivesical space. This sagittal view shows that these pelvic extraperitoneal spaces, while having their own position, are connected to each other. An acute hematoma has a higher attenuation at non-enhanced CT, about 70 to 90 Hounsfield, and contrast-enhanced CT may be used to document contrast material extravasation in the setting of active bleeding. As we can see in this CECT image, active extravasation of contrast material within a large extraperitoneal hematoma and a collapsed bladder. Another example, we can see acute subfacial hematoma in a patient who had undergone cesarean delivery 3 days earlier. Sagittal image shows a high attenuation collection posterior to the rectus muscle and anterior to the urinary bladder, a finding that is consistent with a subfacial hematoma. Ultrasound demonstrates either a cystic or a complex collection anterior to the urinary bladder. As we can see in this image, subfacial hematoma, in this longitudinal and transverse abdominal image, we can see here a complex mass anterior to the bladder. Significant blood loss can occur with subfacial hematomas, since up to 2.5 liters may accumulate in this large potential space without palpable abnormality. It's important to be able to recognize and distinguish between subfacial and bladder flap hematomas, because surgical evacuation of a bladder flap hematoma may require incision of the peritoneum, whereas a subfacial hematoma can be evacuated without opening the peritoneum. In this patient, we can see concomitant subfacial and bladder flap hematomas. This longitudinal and transverse image shows bladder flap hematoma anterior to the uterus, and subfacial hematoma is evident only on longitudinal scan. In more superficial image, we can see subfacial hematoma obviously. Differentiating subfacial hematomas from superficial wound hematomas is also important, given the potential for significant blood loss with subfacial hematoma. The rectus muscle serves as a landmark in distinguishing between these two types of hematomas, with the superficial wound hematomas located anterior to the rectus muscle and the subfacial hematoma located posterior to the muscle. As we can see here, subfacial hematoma extending anteriorly between the rectus muscles. CT can also demonstrate more superficial complications of the skin, as well as subcutaneous wounds. Separation of the abdominal wall at the site of the incision indicates dehiscence of the skin incision. These images related to a 22-year-old woman who had undergone emergent cesarean delivery and presented with post-operative fever that was unresponsiveness to antibiotics. This axial CT shows a superficial wound dehiscence with subcutaneous gas and fluid. Another axial CT image demonstrates a small hematoma in the left rectus muscle, because at the time of surgery the incision had been extended further laterally into the rectus muscle. Another complication is uterine dehiscence. Uterine dehiscence is characterized by incomplete rupture of the uterine wall, usually involving the endometrium and myometrium, but with an intact overlying serosal layer. Uterine dehiscence is very difficult imaging diagnosis because of overlap with the normal appearance of the uterine incision after cesarean delivery. During pregnancy, ultrasound may show fetal parts and contained amniotic fluid extending beyond the uterus. The defect within the myometrium may be clearly seen at the site of the previous cesarean section. As we can see, this here is an example of uterine dehiscence. In this sagittal ultrasound image demonstrates a large defect in the anterior uterus through which the amniotic fluid and umbilical cord are protruding. Patient had a history of previous cesarean section. This intraoperative photo shows the amniotic sac protruding through a defect in the uterus. When the patient represents postpartum, ultrasound may show a defect in the anterior myometrium, but it may be difficult to show an intact serosal layer sonographically. This is an example of uterine dehiscence. This transvaginal ultrasound in the transverse plane of a patient 3 months after cesarean section shows persistent defect in the anterior myometrium. Ultrasound cannot determine whether the serosa is intact or is ruptured. MRI is the study of choice to evaluate for presence of intact uterine serosa. Same patient as A. This axial T2 fat-saturated image through the uterus at the level of the cesarean sectional scar show small foci of hyperintense T2 signal within the scar anterior to the endometrium. However, the anterior uterine serosa is intact, suggestive of uterine dehiscence. Studies have shown that the clinical diagnosis of uterine dehiscence after cesarean delivery correlates poorly with CT findings. In a study, the imaging studies of 7 patients with surgically proved uterine dehiscence failed to demonstrate the finding. CT features in these patients were non-specific and include free fluid, bladder flap hematoma, pleural effusion, bowel distension, and intrahepatic abscess. Another study found CT to be rather unhelpful in evaluating for uterine dehiscence because of poor correlation between imaging findings and clinical surgical findings. They concluded that CT findings must be correlated with clinical findings. In this sagittal image, we can see a large, well-defined hematoma anterior to the body of the uterus without any biometrical coverage, suggestive of uterine dehiscence. However, in view of large hematoma, partial serosal site dehiscence was considered. But on surgery, uterine wound was intact, hematoma found in the uterovesical region, and 300 grams of blood has been evacuated, and there is no evidence of uterine dehiscence. The presence of a bladder flap hematoma greater than 5 cm and large pelvic hematoma should be considered abnormal and highly suspicious for uterine dehiscence in the proper clinical setting. MR imaging may be better than CT in evaluating for uterine dehiscence because of its multiplanar capability and greater soft tissue contrast, and thus its ability to help identify an intact serosal layer. This image shows uterine dehiscence in a patient who had recently undergone cesarean delivery. The patient was treated conservatively. This sagittal fat-saturated T2 MR image shows a large intermediate to high signal intensity hematoma, the lower uterine incision site that communicates with the endometrium. The uterine serosa is intact. The size of hematoma and its continuity with the endometrium strongly suggest dehiscence. Now, please pay attention to these teaching points. MR imaging yielded the best results in delineating an intact serosal layer in patients with uterine dehiscence and was therefore more likely to helpfully differentiate uterine rupture from dehiscence. Using CT and multiplanar reformatted sequences could be a good initial imaging modality, especially using the reformatted images that are perpendicular to the plane of the incision, most commonly the sagittal images. Another complication is uterine rupture. Uterine rupture is the most severe potential complication of cesarean delivery and is defined as separation of all layers of uterine wall, including the serosal layer, with abnormal communication between the uterine cavity and the peritoneal cavity. More than 90% of cases are associated with previous cesarean delivery, which in classical vertical incision is more common than low transverse incision. Uterine rupture may also be seen in the setting of previous myomectomy, uterine malformations in pregnant patients after major trauma, and rarely in women without any known risk factors at the time of spontaneous vaginal delivery. The presence of gas within the uterine defect extending from the endometrial cavity to the extrauterine parametrium in association with hemoperitoneum increases the likelihood of rupture in the appropriate clinical setting. These axial and coronal CT images show the uterine effect due to uterine rupture. Note increased uterine volume in postpartum phase 2 days after cesarean delivery. Although a simple bladder flap hematoma greater than 5 cm should alert the radiologist to the possibility of uterine dehiscence, large amount of blood or an infection in the myometrium that extends into an infected bladder flap hematoma or parametrial abscess should raise greater concern for uterine rupture, especially if direct communication between the endometrium can be visualized. Now, a few case presentation. We can see here uterine rupture in 33-year-old woman who presented with abdominal pain 2 days after undergoing emergent cesarean delivery. Here we can see broad ligament. This axial CT image demonstrates an extra and retroperitoneal hematomas that are contiguous with uterine incision site. Another axial CT image obtained a higher level shows the left-sided hematoma. These findings suggestive of uterine rupture. Another example, a 35-year-old woman who had recently undergone emergent cesarean delivery or premature rupture of membranes and chorioamnionitis. Axial CT image demonstrate complex gas-containing fluid extending from the endometrium through the uterine wall and out into the peritoneum. There is also complex fluid anterior to the uterus, a finding that is in keeping with an infected bladder flap hematoma. Ultrasound image of the pelvis obtained the same day reveals hyperechoic foci representing gas within the uterine incision extending through the uterine wall and anteriorly into an infected gas-containing bladder flap hematomas. These findings suggestive of endometritis proceeding to uterine rupture. Nonetheless, given the infrequency of these complications and the lack of standardized imaging criteria for diagnosis, the radiologist could suggest uterine dehiscence or rupture in the report. However, because of the poor correlation between the radiologic and surgical findings in uterine dehiscence or rupture, further management of the patient must take into account the patient's clinical status. And the last section is Orient and pelvic septic thrombophlebitis. I decided to explain a general term or thromboembolic complications related to postpartum period instead of Orient and pelvic septic thrombophlebitis. The maternal physiologic adaptation to pregnancy includes hypercoagulability, which is most pronounced near term and in the postpartum period. Virtual stereotype of risk factors for thromboembolism consist of hypercoagulable state, vascular stasis, and endothelial injury. The hypercoagulable state of pregnancy and the postpartum period provides a protective mechanism against hemorrhage from miscarriage and childbirth, but it unfortunately increases the risk for venous thromboembolic disease. The leading cause of maternal death worldwide is postpartum hemorrhage. In the United States, however, where postpartum hemorrhage may be more preventable and manageable, the leading cause of maternal death is thromboembolic disease. During pregnancy, there is a fourfold increased risk of venous thromboembolism that rises to a 20-fold increased risk in the postpartum period, particularly if delivery is by cesarean section, which is associated with increased postpartum complications. There is an additional increased risk of deep vein thrombosis in pregnant women with underlying coagulopathy, heart disease, smoking history, and history of previous thrombosis. There are 3 types of thromboembolic complications may occur in postpartum period, include deep vein thrombosis, ovarian vein thrombosis, and amniotic fluid embolism. I know we are all familiar with deep vein thrombosis, and there is no need to explain it in this presentation. So I begin with ovarian vein thrombosis. Postpartum ovarian vein thrombosis is uncommon, occurring in approximately 0.2% of vaginal deliveries and 1 to 2% of cesarean deliveries. It is nonetheless an important condition to diagnose because it is potentially fatal and clinically may present with vague symptoms and mimic other abnormalities. It occurs on the right side in 80 to 90% of cases as a result of dextrotorsion of the gravid uterus compressing the right ovarian vein, retrograde follow within the left ovarian vein, and the longer length and increased number of incompetent valves within the right ovarian vein. It often occurs in the setting of infection, commonly endometritis, and is then considered septic thrombophlebitis. After delivery, there is a sudden decrease in blood volume and venous flow, leading to increased venous stasis. With superimposed infection, risk for septic thrombophlebitis is increased in the postpartum period. Symptoms include right lower quadrant pain and mild fever. The differential diagnosis includes endometritis and abscess, pyelonephritis, as we can see in this ultrasound image, a focal pyelonephritis with pus accumulation in the perinephric space, and appendicitis. Because of the non-specific nature of the symptoms, ultrasound is often done as the first imaging study. Ultrasound may show a dilated hypoechoic tubular structure between the right ovary and the inferior vena cava, but care should be taken not to be confused a dilated ureter with a thrombosed ovarian vein. This ultrasound image related to a 30-year-old woman with right lower quadrant pain and fever 2 weeks postpartum. Tubular hypoechoic structure starting from the right ovary anterior to the right psoas muscle and draining into the IVC, all of which identifies this structure as the right ovarian vein. It's distended with hypoechoic thrombus and the walls of the vein are thickened and slightly echogenic. On color Doppler examination, no follow is seen inside this structure. Overlying bowel gas may obscure visualization of the lower right ovarian vein, and it's helpful to evaluate the IVC at the level of the inferior right kidney, where it may be possible to see a dilated right ovarian vein filled with thrombus just proximal to its insertion into the IVC. Now, please pay attention to this teaching point. In postpartum febrile patients, sonographic condition of ovarian vein thrombosis may eliminate the need for further imaging, but CT and MRI have been shown to be more reliable in the detection of ovarian vein thrombosis and should be recommended if ultrasound is non-contributory or clinical suspicion remains high. Ovarian vein thrombosis may be dramatic, particularly in the coronal plane, where a markedly distended ovarian vein containing central thrombus and surrounding inflammatory changes are seen. As we can see in the CT image, septic ovarian vein thrombosis. Patient was 12 days postpartum with right lower quadrant pain and fever. This CECT image shows tubular filling defect within the right ovarian vein and associated inflammation of surrounding fat. In coronal CT image, tubular filling defect representing thrombus within distended right ovarian vein. Also, we can see here distended non-thrombosed left ovarian vein where comparison with the right side. Another entity is amniotic fluid embolism. The detection of amniotic fluid embolism continues to evolve as more information becomes available about this highly fatal syndrome. Most cases occur during labor, however, up to 30% of cases occur postpartum, reported as late as 48 hours postpartum in rare cases. These schematic images show a general understanding about amniotic fluid embolism. Amniotic fluid embolism occurs when entry of amniotic fluid or fetal cells in maternal circulation occurs. It can happen to any pregnant women, but chances are high in old age, after trauma, abortion, cesarean section, and instrumental delivery. Normally, there is no mixing of fetal cells and amniotic fluid with maternal circulation, but in some unfortunate rare cases, tear in uterine vein or tear in placenta may occur, and entry of amniotic fluid and fetal cells in maternal circulation occurs. These cells and fluid in maternal circulation moves and works as physical obstruction, works as foreign things, induces anaphylaxis-like reaction, and also had thrombogenic substances causing DIC, severe bleeding, and coagulopathy. And finally, after they reach the heart and lungs, they can cause cardiopulmonary collapse with a cardiogenic shock and pulmonary edema. And in circulation, it may cause DIC with severe bleeding. These very interesting images are from Creative Methods website. The incidence of amniotic fluid embolism has been reported between 1 to 8 and 1 to 80,000 deliveries. This is clinically diagnosis of exclusion, and the diagnosis is confirmed post-mortem with the presence of fetal squamous cells and fetal debris within the pulmonary vessels. Therefore, non-fatal cases may be underreported without pathologic evidence to confirm the diagnosis. Maternal mortality rate is between 40 and 85%, with severe neurologic deficits in 85% of survivors, and neonatal mortality rate is 12 to 20%. Earlier studies showed the presence of fetal mucin and squamous cell within the pulmonary vessels of women who had died from sudden cardiovascular collapse during or immediately after childbirth. Prevailing theory has been that amniotic fluid is forced into the maternal bloodstream via small tears in the uterine veins during delivery and initiate a thrombotic reaction when it reaches the pulmonary arteries. Amniotic fluid contains coagulation factors and particulate matter such as sebum and vernix that may be thrombogenic. It has been shown, however, that amniotic fluid components are present in sputum samples of postpartum women without symptoms and even in women who are not pregnant. Amniotic fluid also contains vasoactive compounds that increase vascular permeability and invoke a mast cell response. Therefore, an alternative theory is that amniotic fluid embolism may represent a form of anaphylactic shock in response to components of amniotic fluid in maternal serum. The observation that more than 30% of women with amniotic fluid embolism have a history of previous drug allergy supports this theory. The clinical presentation is that of acute onset of left heart failure with pulmonary edema and cardiogenic shock, altered mental status, hemorrhage, and DIC. More than 50% of postpartum patients with amniotic fluid embolism may present with postpartum hemorrhage and DIC. The management of amniotic fluid embolism is supportive, attempting to stabilize maternal cardiopulmonary status. Imaging findings are non-specific and includes diffuse bilateral interstitial and alveolar infiltrates in chest radiography and CT. Acute left heart failure is not usually associated with cardiomegaly, and the appearance on chest radiography is suggestive of non-cardiogenic pulmonary edema. The differential diagnosis for amniotic fluid embolism includes adult respiratory distress syndrome, diffuse pulmonary hemorrhage, aspiration, pneumonia. Now, I think it's better to review the teaching points after this long presentation. The presence of a bladder flap hematoma greater than 5 cm and larger pelvic hematomas should be considered abnormal and highly suspicious for uterine dehiscence or rupture in the proper clinical setting. The pelvic extraperitoneal spaces, while having their own position, are connected to each other. Significant blood loss can occur within subfacial hematomas, since up to 2.5 liters may accumulate in this large potential space without a palpable abnormality. It is important to be able to recognize and distinguish between subfacial and bladder flap hematomas, because surgical evacuation of a bladder flap hematoma may require incision of the peritoneum, whereas a subfacial hematoma can be evacuated without opening the peritoneum. The rectus muscle serves as a landmark in distinguishing between subfacial hematomas from superficial wound hematomas, with the superficial wound hematomas located anterior to the rectus muscle and the subfacial hematoma located posterior to the muscle. MR imaging yielded the best results in delineating an intact serosal layer in patients with uterine dehiscence and was therefore more likely to help differentiate uterine rupture from dehiscence. An infection in the myometrium that extends into an infected bladder flap hematoma or parametrial abscess should raise greater concern for uterine rupture, especially if direct communication with the endometrium can be visualized. In postpartum febrile patients, sonographic detection of ovarian vein thrombosis may eliminate the need for further imaging, but CT and MRI have been shown to be more reliable in the detection of ovarian vein thrombosis and should be recommended if ultrasound is non-contributory or clinical suspicion remains high. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.